Sir, please start. Madam?
Sanjay Joshi, sir.
Sanjay Joshi, sir, please start.
Am I audible?
Yes, sir. Please start.
Yes, sir.
So, good evening, my dear IIPians. I welcome you all to this Jara Hatke Friday Punch. The concept here is one of our colleagues is going to present one case, and the two other of our colleagues are going to tell us how should we approach to the particular case. Finally, they will solve the mystery and of the diagnosis of the case, and they'll become the Sherlock Holmes. Remember, the main concept here is how should we approach to a particular case and not the final diagnosis. So this is going to teach us how should we approach it and not the final diagnosis. I welcome you all. I welcome you all on this Jara Hatke Karyakram. I welcome our president Pakmode sir. I welcome Dr. Amol Pawar sir. I welcome Dr. Minas sir. Minas sir has joined. Minas sir. I welcome Dr. Sanjay Deshmukh sir. I welcome Dr. Jaya Shivalkar madam. I welcome our crackers, Dr. Mahesh Kore sir, Dr. Leena Dhande madam, and the presenter moderator, Dr. Sanjay Nathu and Dr. Abhishek. I now request our president, Dr. Pakmode sir, to please address our meeting. Pakmode sir, please.
Unmute.
Good evening. Namaskar. Thank you, Sanjay Joshi, sir.
Yes, sir.
Now, this last means Friday of the every month, we say, we are alternative doing the activities of Friday Punch. First Friday in the month of January, we have done with the 5 representatives from the 5 regions, and alternate with this, we thought of doing this case presentation, a Maha case. So as the sir has rightly said, for solving any case or any mystery, you have to start from the beginning. So I remember always Dr. Y.K. Amdekar says that nowadays touch is replaced by so many machines, and if you go in a proper way, as we take that is back to the basics, that is the proper history, geography, then science, and then the mathematics, I think you will reach to a proper diagnosis and you can treat the patient properly. The sir used to say that you should have always a third eye. With the third eye, you can see what means you can watch, or you can watch those things in the patients. So from the beginning only, from the history, you can elicit something and you will reach to the symptoms. From the symptoms, then the signs, and then the diagnosis, and then the treatment. So, but nowadays we see nowadays everybody is in hurry in making a diagnosis with the machines and investigations and prescribing the drugs. But to really do the justice with the patient, we need to go in a logical fashion or in a proper fashion as we have been taught in the undergraduate days. So I think this is a beginning, which is of this Friday Punch in the today is going to teach us. Again, we are going back to our UG days, where how we used to take the history and then the complete examination of the patient, and then the investigations, and then the proper treatment. So let us go back to the basics. Today we got the 2 experts, Dr. Kore sir from Nipani and my batchmate Dr. Leena Dhande from Nagpur. And presenters of the case, well-known Dr. Sanjay Nathu sir and Abhishek Srivastav, JR2, who is working in SKN Medical College, Pune. So I welcome you all, the experts and the case presenters and the moderators and all the other office bearers of MahaAP and our secretary, Dr. Amol. And I must say congratulate to Dr. Sanjay Joshi and Minhas sir for taking the extra efforts for this particular Friday Punch. Thank you. Jai Mahai. Over to Amol.
Yes, thank you. Thank you, Sanjay Joshi sir, for moderating this very important session. As you all know, many of the Maharashtra IIP members might be knowing that in last 2-3 years, we are doing such case presentations, MahaIP case challenge, and other activities we have done in last 3 years. This is also well thought initiative, cracking this case, cracking the cases, and I must congratulate once again to Dr. Meena Sheikh sir and Sanjay Joshi sir for taking this initiative, and also first our opening batsman, my dear friend Dr. Sanjay Natu sir. He will be moderating this session along with his JR2, Dr. Abhishek Srivastav, and the crackers will be senior pediatrician Dr. Mahesh Kore sir from Nipani. Even if he is in Karnataka Nipani, but he belongs to Maharashtra. He is one of the member of Kolhapur IIP, and Dr. Leena Dhande ma'am also. Actually, this will be very much useful to all the UG students as well as PG students who are doing their degrees. And I will request all the members who are joined, all the office bearers, to circulate this link and flyers to all the medical college professors, HODs, so that they will be forwarding it to the PGs, and so it will help them in cracking the in their case presentations and in their Vivas exams also. So all the best to this program. Over to you, Dr. Sanjay Joshi sir.
Thank you, Amol. Thank you for your kind words. And really, I think it will be very useful to all the PGs also. Now, I request Dr. Sanjay Deshmukh sir to please address the meeting.
Good evening. On behalf of MahaIP, we welcome you all office bearers of MahaIP 2025, our EB members, our women committee members, our scientific committee chairperson, Dr. Meena Sheikh, Dr. Sanjay Joshi sir. Amol has rightly pointed out, this platform is very important platform for the PG and graduates. So I hope in future we will want more and more people on this platform, because this is the platform where we can learn the basics of case prediction. And today we have two experts, Dr. Mahesh Kore sir, Dr. Leena Dhande ma'am, and moderator Dr. Sanjay Natu sir. So this is a great opportunity, and we should thank our scientific team, our secretary Dr. Amol, President Dr. Pakmure, for beginning this session. And I wish all the best, and I think it will be the Drishyam-like thing for us to crack the case. We don't know what Dr. Srivastava used to present today. So let's hope we will crack the case. So over to Dr. Joshi sir. Thank you.
Thank you, sir. Thank you. I request Dr. Meena Sheikh sir to address the meeting. Is Dr. Meena Sheikh there?
Yeah, yes, I'm there.
Yeah.
Yes,
Sir,
good
please.
evening. At the outset, thank you all who have consented for this particular session. And rightly said, it's a great session to understand the basics. The important part is that the case is blinded over here. The crackers does not know what is the case, and that is the beauty of this. So let's start with the great beginning. Thank you all.
Thank you, sir. Thank you. Let me introduce the crackers. The first cracker, Dr. Mahesh Kore, is a senior pediatrician from Nipani. He runs an NICU and a pediatric hospital in Nipani. He's a very excellent academician, and he has written a chapter on brucella in IIP infectious disease textbook. He's a recipient of many awards. So I welcome you, Dr. Mahesh Kore, sir.
Thank you, sir.
Our second cracker is Dr. Leena Dhande, madam. She is involved in research. She is at present professor and HOD in Government Medical College, Gondia. She has a special interest in pediatric nutrition, neurology, and statistics. She's involved in research in many places. She's a principal investigator in various projects. She has presented many papers on international and national platforms. She has got many publications in her account in international and national journals. She's a co-author of many books. She has written chapters in pediatric books also, attended many conferences. So she's a very really multifaceted personality, and I'm sure that she's enlightened us today with how do we approach to a difficult case. Thank you. We welcome you, Lina, madam. Hello.
Hello.
Lina
Yeah.
is there?
Yes,
Hello.
yes, I'm there, but I
Is
muted
there?
myself.
Yeah, okay,
One more introduction I'll add. She is my batchmate.
Okay.
Thank you so much.
Our moderator, Dr. Sanjay Nathu sir, is a professor and HOD Department of Pediatrics in SKN Medical College, Pune. He's also a consultant at Shashwat Hospital, Pune. He's been a faculty in several national and state conferences. He's got special interest in pulmonology, infectious diseases, and emergency medicines. So I welcome you, sir, on this occasion.
Thank you, sir.
Thank you. And our presenter, Abhishek. Are you there, Abhishek?
Yes, sir.
Yeah, Abhishek is JR2, enthusiastic young blood. So let us hear the case from Abhishek. I request Abhishek to start the presentation.
Yes. So just allow me to share the presentation.
Yeah.
Can everyone see the case, the slide?
Yes, sir.
Yes, sir.
Yes.
So I'll ask Abhishek to begin in just half a minute. I welcome all of you, and I thank Dr. Sanjay Joshi sir for giving our college and myself and Abhishek this opportunity to be the opening batsman in this endeavor for this year. We have got an interesting case, but with some common presentations. So I'm sure we'll have a lot of discussion, and with esteemed case crackers like Dr. Kore sir and Dr. Leena ma'am, I'm sure we'll have an interesting discussion. So I request Abhishek to proceed. I request Dr. Kore sir and Dr. Leena ma'am to intervene wherever they feel they need any more information. They can just ask. If the relevant information is available, we'll keep on adding it. And we have also kept the information flowing regularly and kept slides in between when we can interact. So I request Abhishek to proceed.
Good evening, everyone. The case, informed being father, 8-year-old, 6-month-old female child, referred with complaints of swelling all over body since 5 days, fever since 4 days, difficulty in breathing since 4 days.
So this is the very basic chief complaints, and I would like to ask the experts whether this rings any bell in their minds.
Yeah. So I will start because I'm a general practitioner. And after that, Lina madam can add as she's a professor. Okay. Swelling all over the body is a first complaint. So we can have 4-5 groups for swelling anywhere in the body. Can it be cardiac? Can it be renal? Can it be GI? Or can it be liver disorder? Or last is immunological allergic. So, if there is no difficulty in breathing, yes, there is difficulty in breathing since last 4 days. It means more likely to be a cardiac than any other, but severe anasarca-like thing can have difficulty in breathing also. So we want details of this swelling has started first or breathing has difficulty of breathing has started first.
Yes, sir. We'll come to the HOPI, sir.
Okay, and fever, I would like to know details
can
about
we-
the fever. And let the Lina madam add anything else if she wants.
Yeah, one question. Where did the swelling start from?
So
Yeah,
we'll just
details
go to
of the
HOPI.
swelling.
Abhishek,
Yeah.
you can proceed.
So the patient presented to our from our outside hospital. Swelling started from over the face, insidious onset, gradually progressed, generalized anasarca over 5 days. Fever was moderate grade, intermittent, not associated with chills and rigors, relieved on medication, and the child was active in interfebrile period. Fever subsided after 2 days of illness.
So if the swelling has started over the face and then has progressed to become anasarca, so we as PG students never use the word generalized anasarca because anasarca, it is understood that it is generalized. Okay, so that's a small suggestion. So it has progressed from the face to involve the rest of the body. We should primarily suspect a renal cause, and your fever is not associated with chills and rigors. So I'm considering that probably that fever could be associated with the focus of infection somewhere. And I want to know in the past whether there is history of swelling in this child. Okay. So that nephrotic or some similar presentations can be thought of. And the respiratory difficulty probably is arising from pleural collection is one thing which is coming in my mind because you're saying there is anasarca. So you can proceed further.
Yeah.
Initially,
So there is-
fatigability, which progressed to
Right.
difficulty in breathing, breathlessness on exertion, dyspnea on walking and difficulty in breathing on lying down over 4 days. Child had received IV antibiotics and blood transfusion. Child was on non-invasive ventilation for 2 days. At this point of time, the child was referred to our hospital.
Yes, Kore sir wanted to say something.
Yeah.
Yes, sir.
There is some unusuality in this case. What is the unusuality is the anasarca has progressed rapidly over a period of 5 days. That is one. Or the child was breathless within on a second day itself because anasarca swelling was there for 5 days and breathlessness was there for 4 days almost. Okay, this type of anasarca is not generally seen in what we call as a renal. Renal means one is endothelial disorder and second is epithelial disorder. Endothelial will have hypertension, hematuria, all these things. So we are suspecting generalized swelling, that is anasarca, because of epithelial disorder, prototype diseases, nephrotic syndrome. But nephrotic syndrome patients are very stable. They will not come within 1 or 2 days to the hospital, or they do not deteriorate so fast. So any acute accumulation of the fluid in the body can be there over the face. It is not sacrosanct with the renal disorder. That is my now, because its story is unusual in this case. So we have to think of other. Breathlessness has come after the swelling. Probably breathlessness is due to the accumulation fluid, as madam has said. But a rapid accumulation and breathlessness on a second day put this child on a very immunological or allergic manifestation. That is a second group I am catching on at this point of time.
Excellent analysis by both the experts. I think the important chief complaints have been well dissected. Abhishek, you can just proceed.
Negative history. There's no history of palpitation, cyanosis, syncope, chest pain. There's no history of jaundice, abdominal distension, altered sensorium. There's no history of decreased urine output, cola-colored urine. There's no history of change in urinary frequency, volume, and painful micturition. There's no history of headache, blurring of vision. There's no history of rashes or any recent travel.
Any other histories you would think would be important, sir, ma'am?
There was one history that he has received blood.
Yeah, in the present admission before presenting to us, he had received blood.
Why he has received that blood, whether it was really indicated, we'll come to that afterwards.
Yes, sir.
But giving blood at any private hospitals means that he has anemia along with this. So anemia with edema and this 8 years child and started with swelling, not a fever. A fever has come afterwards, I think. Okay.
Fever was at the initial, sir, couple of days, and then it disappeared. Actually, fever lasted only for 2.5 days. Then the fever was not there.
Yeah. So what I gather from your history is fever is not a prominent feature in this case. Fever is just inflammation, and that can be because of non-infection causes like this. In this, edema has caused. Then he has breathlessness and rapid progression of edema. Okay, so fever is become a minor element in this. It is a accompanying symptom. It is not a major symptom. So inflammation is not that major, but edema is major part in this category. So we have to dissect that edema, how fast it has progressed, where it has gone, and why there is a anemia, whether there is a really anemia, and for that anemia he has received, or he was in congestive cardiac failure. That's why they have given blood transfusion, PCU transfusion probably. That I want to ask.
Okay, we'll just go ahead and there'll be some important inputs which will give us some clue. Anything else, ma'am? Anything you would want to know?
Yeah. Is there history of any drug intake, any vaccines, or any insect bites or any other bites?
No, ma'am.
Okay.
Okay, we can just proceed to the next important input which we will get.
Swelling and
Okay.
anemia, I will write down.
In past history, there is history of anemia with respiratory distress requiring admissions and blood transfusion. First admission occurred at the age of 12 months. Till date, there have been 6 admissions and 6 transfusions were given. She never required ICU before this episode. There is no other major illness reported in the past.
So now there's history of recurrent admissions with transfusion to add
Okay,
on to
and
the previous history.
he required only 6 transfusion up till now, up to 8 years.
Right. So each admission, what we could gather was probably it was because of some similar complaints, and he was found to have anemia and was probably transfused each time.
Okay, so now we have got edema as one presentation, and anemia is a major component now. So at anemia, we can dissect it on a 4 groups, whether it is a deficiency anemia, whether it is a hemolytic anemia, whether it is a bone marrow related anemia, or whether it is a hemorrhagic anemia. So deficiency anemia is almost out. Hemorrhages, low grade hemorrhage inside the body can be there, but will not present. So major components become whether it is a hemolytic anemia or bone marrow component is there. These are the 2 groups I am looking at. And then along with this, whether the edema can cause, what is the cause of that edema? We have to correlate with this. And he has survived well up to this 8 years, requiring only 6 transfusion, means probably he is not a transfusion dependent thalassemia major that we have ruled out probably. Intermediate can present like this, sometimes requiring. So we'll like to know whether he had a hepatosplenomegaly, what are the platelets count will come gradually over
The
that.
examination,
But
right?
hemolytic anemia and bone marrow anemia, we'll keep this at. Hemorrhage less likely, deficiency are ruled out.
Ma'am, anything to add?
Yeah, I like to ask whether the respiratory distress used to get relieved with the blood transfusion, and it used to present only with anemia. In the was there a dissociation between the two, or always they were coming together and getting relief together?
So actually the admissions, what they told was he usually had some respiratory complaints and used to get admitted. And at that time anemia usually was detected and they used to get transfused. And yes, he used to improve over the next couple of days or 3 days.
With the respiratory support improved or only with blood transfusion improved?
Probably some medicines also used to receive and the blood transfusion. No respiratory support before this episode.
Okay, so there are no 2 points. Whether respiratory distress
no
is
respiratory distress. No. Like
yeah,
there was
go
no episode of just distress without anemia is my question.
At least from the parents, we could not get any different episodes without respiratory complaints and anemia. Each time they were there together.
So if we put this together, respiratory distress and anemia together, then we can think of whether there is a bleeding intra-alveolarly pulmonary bleed can. So we have to think. And there is one condition called as immune-mediated pulmonary hemosiderosis. We can think of it can be allergic, it can be immune-mediated, and swelling can be then immune-mediated.
So we need to ask whether she was producing sputum and was it rusty colored or something. So
no
that is one
sputum previously.
Yeah.
Okay, we'll move ahead. Abhishek.
There is background noise. Somebody has to mute them.
Done, sir, done.
Okay, thank you.
First, in family history, first two of the children were born non-consanguineous marriage. There is no history of any major similar illness in the family. There is no history of couch contact. Birth history, immunization history, and development history were normal. In summary, a 8-year-old, 6-month female undernourished child with past history of multiple admissions and transfusions, present with progressive edema and breathlessness with initial fever.
So, what would be the initial differential on history, whatever we had like dissected till now? Any comments?
As she has started her illness right from the 1 year of age, and she received blood transfusion, and up to 8 years she's been undernourished, means weight has been affected and as well as height has been also affected. So it is a chronic progressive disease requiring blood transfusion intermittently and now developing anasarca.
Right,
So
sir.
our bet will be on chronic progressive disease.
Okay.
Agreed.
Shall we move ahead?
Yeah.
On anthropometrically, weight is less than 3rd centile, height is between 10 to 25th centile, and BMI is less than 3rd centile. She is undernourished.
Weight is more affected than the
Yeah,
height.
but then you mentioned about anasarca, right? So
Yes, ma'am.
these parameters are with the anasarca situation?
Yes,
Ma'am,
on
actually,
admission, actually. This was
on
the weight on admission. So, yes, there was some element of swelling anasarca at that point of time.
Oh, means we can reduce 2 or 3 kgs from that. It must be real 13 kg and 120. But still, it will go in favor of acute on chronic disease. Like weight is more affected than the height.
Right,
And
right.
height is not that, means 10 to 25 centimeter, and it has to be
Acceptable, yeah.
corrected with the parental height, mid parental height.
Right.
Correct.
So, we'll come to the
Clinical.
examination.
She was afebrile, heart rate was around 160, that is tachycardic. She was tachypneic with subcostal and intercostal contractions. BP was between 50 to 95th centile, and she was maintaining saturation around 68% on room air.
Okay.
Peripheral pulses were felt. CRT, capillary fill time, was less than 3 seconds. Pallor was present. Clubbing was present, that was grade 3. Edema was present bilaterally, pitting edema up till knees. JVP was raised. There was no icterus, cyanosis, lymphadenopathy. Rest, head to toe examinations were normal. On systemic examination, S1,
Faces,
S2.
were they hemolytic? Were the faces hemolytic?
No,
Have you mentioned
no,
it?
ma'am.
I missed it probably.
Clubbing has
She
added.
didn't have any peculiar faces.
No specific faces, ma'am.
Any other nutritional deficiencies because she's a nutritionally compromised child?
So, at least on general examination,
Knuckle,
we did not find any signs of any gross nutritional deficiencies.
knuckle pigmentation or anything?
Her complexion itself was quite dark, ma'am. So, we were not able to appreciate any specific knuckle pigmentation as such.
But
Any
there is
bleeding
one point.
spots?
Go back to the previous slide. Yeah, clubbing grade 3 is some important finding here, and it will suggest that the child has been chronically hypoxic, and there must be some cause for that. Either chronic respiratory condition can cause this, or there has to be AV malformations to lead this, if there is no cardiac problem.
Dr. Abhishek, you should also be aware of other causes of clubbing than hypoxia. There are certain other causes of clubbing which should also be considered.
Yeah,
Can
madam.
you enumerate a few of them?
Ma'am, any lung pathology, chronic lung pathology can cause clubbing, which is bronchiectasis.
Cardiac, lung, GI, and miscellaneous. You can divide into this.
Yes, because that is one kind of prominent finding which is setting the whole thing in a different direction. So you'll have to really focus on that and think of other causes. Sir already gave you the headings. You just have to fill in the blanks. Okay, you can think about it. आगे जाओ.
Abhishek, you can go ahead.
Yes. On system examination, in CVS, S1, S2 heard, gallop is present, no murmur appreciated. On our respiratory examination, air entry is mildly reduced in infra-axillary and infrascapular areas with bilateral treps present. On per abdomen examination, liver is L2 is present, that is liver span is around 9 centimeter, soft, mildly tender, no free fluid, and spleen is not palpable. Patient is conscious oriented and there is no focal neurological deficits present.
With this systemic examination and our history analysis, would we like to make some provisional diagnosis, sir, ma'am?
Go back to previous slide, sir. Gallop is there, means he is in congestive cardiac failure, maybe because of anemia or maybe because of some other reasons. And there is no murmur to suggest that there is some flow murmur. There is no flow murmur. And I will not think of subacute bacterial endocarditis at this point of time to say that it is a cause for that. But I will keep this in mind that there was a gallop, the baby is in congestive cardiac failure, and there is a reduced entry infraaxillary, infrascapular, bilaterally. Means there is some with the anemia, there must be some bleeding, intraallural bleeding. Our thinking is going that he must be having intraparenchymal bleeding repeatedly. Span of the liver is 9 centimeter for that 8 years child, slightly higher, and mild tenderness. Mild tenderness can be because of congestive cardiac failure, congested liver. Per se, liver mild tenderness will favor actually congested liver. There is no free fluid. Spleen is not palpable. Means we are now not dealing with a typical hemolytic anemia group of thing where anemia is recurrent and required blood transfusion. But from the patient's house, it was not fitting into hemolytic anemia. So combining these two, anemia, recurrent anemia, having recurrent respiratory admissions, and now going into failure, pulmonary hemosiderosis, immune merited, or there is some other cause for that anemia. Myelodysplastic syndrome can present like this, and anemia itself can cause failure, but that is second line thinking. Madam, Lina madam, you can add it, anything.
Yeah, you have correctly dissected it, sir. The cardiovascular, like the compromise could be due to pulmonary hypertension, the fibrotic changes and the pressure effects. So that could be one additional thing. Other than that, either there is a bleeding in the lungs because we need to explain anemia as well as we need to explain the both the things, the distress as well as the requirement of blood and everything. So anasarca. So I think that falls in place correctly. Could we think of any other probable, because this is particular areas, but they are bilateral, infra-axillary and I think the slide has changed.
Sorry.
Yeah, infrascapular. So there it's a symmetrical, it's not a localized thing. Otherwise, we could have thought of some congenital lung anomalies which are causing the problem, but this is not looking like it. Okay. We can go to the next slide.
So just for the sake of discussion, would any of these be fit the bill?
Nutritional less likely in this case. Hemolytic spleen is not palpable, which makes this again less likely because hemolytic anemia will present with splenohepatomegaly, splenomegaly. There are few very rare conditions where they will present with intravascular hemolysis, but there was no history of hemoglobinuria in your child. Okay, celiac disease will present with short stature anemia, but will not cause, it will cause clubbing sometimes, but will not cause a respiratory distress in this child, what we are expecting. Hypoplastic bone marrow syndromes are less on card, but we have to keep them as cause of But keeping this together, it rather favors a bleeding in an intraparenchymal lesion of the lung or AV malformation, which is recurrently bleeding, and that's why he has a clubbing of grade 3 also, which can cause a shunting from right to left. They will behave like a cyanotic heart disease like patient.
Okay, we'll go to the labs.
But
Yes,
she
ma'am.
has only clubbing and no cyanosis, is what we have been told.
Yeah,
Only clubbing.
but he
right?
was hypoxic, madam, because he was pulse ox was around about 60 or 70, I think, initial.
On admission, yeah. On room air, it was 68 to 70 on room air.
Yeah, that, and with this only bilateral infra-axillary, infra-clavicular, it is not explainable that ARDS will present with this, but hypoxia of 7, SpO2 of 70 is disproportionate to the clinical finding of your respiratory. So there has to be something else, means right to left shunt intrapulmonary area.
Okay, we can go. Yes, ma'am.
Yeah. This was a question for Abhishek, that a patient coming with severe anemia, why do you think you miss the cyanosis?
Yes,
Back
ma'am.
to
Can you
basic.
repeat, please?
We are reporting a 60 to 70 saturation, right? But
Yes,
no
ma'am.
cyanosis has been seen in this patient, and your patient also had got probably severe anemia. We are yet to look at the investigations, but probably she was severely anemic with anasarca is what I presume. She had received a blood also, right? So
Yes, ma'am.
probably that was for severe anemia. So can you tell us why the patient's cyanosis was missed? What is the physiology behind it? What is the minimum amount of desaturated hemoglobin you require for detection of cyanosis clinically? And that is the reason why we miss cyanosis in patients with severe anemia.
Is it 5 gram, Abhishek?
So
Yes.
Abhishek, it is 5 gram %.
Okay.
Yeah.
With
Just to say
anemia,
yes
you're
only.
unlikely to get such a high amount of 5 gram % of what you said, deoxygenated hemoglobin, and that is why you would not get clinically apparent cyanosis, though the child may be hypoxic.
In anemic patient.
Yeah, when the hemoglobin is low, that is difficult. So coming to the labs, Abhishek.
The two labs we have comparison is from the outside hospital and at our hospital when the patient was admitted. In the outside hospital, as we can see, the hemogram was 6.3, 6,400 counts, 2.6 lakh platelets, and 19.7 hematocrit. And our post-transfusion, when she was shifted to our hospital in comparison, the hemoglobin is 8.8 with 25,000 counts, with band cells of 3, neutrophil 70%, and lymphocyte 20%, with platelets and hematocrit being normal. CRP initially was 19, and later at our hospital was on 57.5. LFTs was done not done at our hospital, but at the previous hospital was the total bilirubin was 0.43, direct was 0.17, SGOT was 48, SGPT was 42, and ALP was 129. Serum protein and serum albumin was about around 5 and 2.6. LDH was 728. BUN creatinine is raised, as we can see. It's in 64 in the outside hospital and 1.6 creat, whereas in our hospital, the urea is 101, 101, and 1.3. ABG had 7.27 PCO pH with PCO2 of 34, PO2 of 94.3, and bicarb of 15. Dengue was negative, blood culture and sensitivity was negative, and GL for CBNAT was also negative.
So this was ABG was done after the child was taken on ventilatory support, and of course the blood culture came later on. But just to complete the list, we put it here.
Okay, but added finding is that child has a acute renal injury or a chronic renal CKD type, but with most likely to be because child was requiring hypoxic child, hypotension, probably there was a hypotension mentioned.
No,
The
no
child was
hypotension.
no hypotension. There was not a hypovolemic child when you received that child. But severe anemia, they must have given blood already there. Probably that prerenal element is not that much if you think that the child was not hypotensive, so there is an element of AKI in this case. AKI can be secondary to the hypoxia and all multi-organ this one involvement, or itself can have these three now: renal involvement, a bone marrow or a blood anemia involvement, and now the AKI part has come.
Or it
Hemolytic
could be due
uremic
to some
syndrome, less
disorder.
likely.
Exactly. So it could be due to a condition which affects the lungs and the kidneys both, such as Dr. Abhishek.
Ma'am, good pasture can be a differential kidney for lung
One
disease.
of them. Yeah. So you should keep these things in mind.
Yes.
Any other?
And IPH also can affect. Immune-mediated pulmonary hemochromatosis can also
Vasculitis,
affect
any kind.
vasculitis, small vessel vasculitis.
Yeah. Yeah.
So we are strongly suspecting small vessel vasculitis in this case because lungs in involved, edema is there, which suggests the capillary leak, and this now blood urea serum creatinine high on card, high. But
Have you
there is
looked at
no
the
rash,
cardiac
no.
parameter? Sorry.
Yes, ma'am.
There
Yeah,
was
have
a
you
rash,
looked at the
sir.
cardiac parameters?
There
No
was
rash.
And we did not do any separate cardiac parameter test, ma'am.
Okay.
This was
But
the X-ray
lung,
on admission.
on X-ray, lungs are equally bad. I thought that they are not that bad, but they are really bad, and there is right homogeneous mid zone, lower zone, left mid zone, upper zone, everything is involved, more on the right side than the left side. And whether it, I cannot say that they are restricted to the lobar segment as such, in a low pneumonia type. It is not a classical of pneumonia. So they are bilateral, generalized, and if anemia is associated with this condition, I will again strongly suspect intra-alveolar bleeds.
So the initial X-ray reporting was suggested. The radiologist reported as suggestive of pulmonary edema, and the initial USG abdomen showed mild hepatomegaly. The edema is misprint and mild ascites. Any other
Okay.
investigations you would suggest at this stage?
Yeah. First, I would like to do a gastric aspirate for macrophage, iron renal macrophages. That will directly give evidence that he was bleeding inside, rather than a ball in this case. And once you are ventilated, you can do directly ball for iron Linden macrophages. And because infection is not high on card and blood cultures are negative, the child is not that toxic to say, and your CBC parameter does not favor any toxic granulation or infection parameters as such. So infection is less likely, and she's requiring repeated admissions with anemia, respiratory distress, and along with this is treated now. So there is a severe bleed intraparenchymally lungs. Or what is the cause of that bleed? We have to find out whether it is immune mediated or whether it can be structural. Structural means there must be a EV malformation. If hypoxia doesn't improve on ventilation also, and echo suggests there is no right to left shunt, then we can do a contrast echo to prove that the bubbles are coming on the right side very fast or on the left side very fast.
Any other investigations, ma'am?
Urine protein 1 plus RBCs 10. Yeah, there is evidence of hematuria in this case. 1 plus protein will come with that. And it will also again favor our original thinking of small vessel vasculitis. And a second line of investigation will be all ANA and all these things.
Yeah.
ANA, ANCA, PANCA, CANCA, ANA, DSDNA, all this. But first, I would like to do a gastric aspirate for this one.
Abhishek?
Yes, sir. The progression in our ICU, child was intubated and received one PCV transfusion, injection furosemide, injection ceftriaxone. And over the next 36 hours, she improved and she was extubated and taken on triple HFNC.
This is also a clue that 1 minute. Child, such a bad X-ray improves within 3 days and can be extubated, will not happen in ARDS or infective etiology of any kind, maybe bacterial, maybe viral, maybe fungal. So this was a bleed which has cleared so fast. That's why you were able to extubate her.
In detailed past history of the previous admissions retrieved from the parents, she had been earlier done a anemia workup properly in 2019, which showed dimorphic anemia. HB electrophoresis was normal. Bone marrow system of erythroid hyperplasia and low B12 levels were also documented. Negative history for anemia. There's no history of loose motion, constipation. There's no history of purpura petechiae. There's no history of bleeding.
Any additional workup, as Sir has just suggested, one is for the macrophages we would want to do, BAL or a gastric aspirate. Anything else you would want to do for anemia?
Anemia will reticount. I want to know about reticount. And bone marrow is already normal, hyperplasic. So that's is bone marrow is not involved. Okay, so reticount must be higher
This
because
was an old, this was an old workup, right?
Yeah, this
So
was the old
do
one.
we
This was the
plan
old
to
one.
do it now? Yeah, so bone marrow study is kind of necessary now. So we know the progression or otherwise of the disease. And B12 levels need to be worked up, and whether she was on B12 or not in the treatment history. What is the cause?
not to
Right.
say, but the anemia was normocytic, normochromic. Now, you know, because I
Yes,
felt that MCV is
normal.
86 or 89 only.
It was normal.
Normal. So megaloblastic has been ruled out on PS wise. Or there was hypersegmented neutrophils there.
No, bands were there, but no hypersegmented neutrophil as such described in the peripheral smear.
Okay.
Further workup done for anemia. TTG IgA was negative. IgA was 404. Stool for occult blood was done, which was negative. Sputum for hemosiderin latent macrophages was also done, which came positive.
So the sputum cytology showed us pigment-laden macrophages, which were positive for hemosiderin pigment. These are just few of the films of the sputum which were given to us by the pathologist. So they were, as both of you have suggested, hemosiderin containing macrophages were found out in the sputum of this child. We also did a HRCT thorax. We showed ground glass attenuation involving both lungs with some interstitial thickening, few bilateral pleural effusions, and airspace opacification with cavitation in medial segment of the right middle lobe, with mediastinal lymph nodes as well. So the imaging differentials, what the radiologist suggested, where of course pulmonary edema was their initial differential, but they also thought about pulmonary hemosidrosis and infection as a remote possibility for all these things. Anything else? Any clue? Any more clue you could find in the CT or?
सर एक्स में पढ़ने इतना डिफिकल्ट है तो सिटी किधर से पढ़े?
No, sir. We can just make out from what the radiologist gave us. So this airspace opacification with cavitation, does it ring a bell?
Cavitation can be a small vessel vasculitis. The thin wall cavitation will favor small vessel vaginous. We call it as initially vaginous. Now we don't call it as a vaginous. We call it something else.
So the same thing was reported by the radiologist. Of course, they always report the infection as first, but they also thought that it could be related to the cavitation, related to the vasculitis, as you rightly suggested. So this is just the summary of the last few investigations which were done. Stool occult blast negative, sputum showed hemosiderin macrophages, and HRCT showed the findings as discussed. So diagnosis, as our expert crackers have dissected, we made a diagnosis of pulmonary hemosidrosis. However, the case progressed a little bit more. Abhishek?
At this point of time, we'll not say only pulmonary hemosidrosis. because lungs are also involved. Capillary leak is there, anemia, and kidneys are also involved. So we will say that it is a small vessel vasculitis, probably granulomatous polyangiitis or something else. There are one or two trust which is not common in children, but it is now called as a polyangiitis. Venous granulomatous is now replaced by the granulomatous polyangiitis.
Perfect. So that is how the case played out actually subsequently. Yes, Abhishek.
Further goes in ICU. Patient developed hypertension over next few days. Started with injection labetalol, and patient had later convulsion, was re-intubated in view of poor GCA. Started with injection Levera. Immediately brain imaging was done. She had subarachnoid hemorrhage with press. Later, patient needed multiple antihypertensives for like labetalol, amlodipine, and prazosin. On imaging differential.
First methylprednisolone was given to this case.
Not yet, sir.
I should
Before
have given
that,
that.
she developed hypertension.
No. It should have given prior to this because that is a life saving. Once you diagnose iron macrophages, we should pulse them because
So,
we
sir,
had a similar child and we pulse them, and within with pulse they will settle. Because they will not go into hypertension, they will not go into other complications because
Correct.
these conversions can be because of small vessel vasculators of CNS. And
right.
again, one more, hypertensive encephalopathy. Both can cause.
So by the time we were reaching our diagnosis, the child had progressed with
Yeah. That
hypertension
that
and
is
press.
real life. That it is not that easy. I know.
Later imaging was done. On imaging, sulcal flare hyperintensities were present, which suggested of subarachnoid hemorrhage and meningitis, but less likely in view of all the labs and previous suggestive that was present. Hypodensities in the bilateral parieto-occipital parenchyma appearing bright on DWI and flare, but not showing restriction of diffusion, which was likely considered vasogenic edema, which was due to press, as the BP had suddenly risen the patient.
Hypertension.
Yes, hypertension.
And they are typically of parieto-occipital, right? Bharat?
Yes. So these are the trends since the admission till the discharge. As we can see, the BPs are always on the higher side, that is between the 50th and the 99th centile. And at day of admission 14, it had risen, and the BUN creat initially was very high, then later, and creat and BUN both were high with output which was initially better, as she was on furosemide when we had initially started when the patient had come. But later when we stopped furosemide, suddenly the output dropped, and the output at day of admission 9 was very less, that was less than 1 ml per kg per hour. And the creat and BUN both were raising trends. So we had initiated in between the peritoneal dialysis was also done with that patient. The further course in the ICU, after 48 hours, patient was extubated, taken NIPPV, CPAP, and ultimately in O2 by nasal prongs. In view of persistent RFTs, as you can see in the trend, PD was started. Further, ANA, C3, ANCA, urine protein creat ratio, renal Doppler, and renal biopsy was done. As we can see, ANA is weakly positive. And ANCA was anti-double standard DNA was negative. C3 was 78 and C4 were also in normal range. Both were normal. C3, C4 normal. ANA by indirect immunofluorescence was positive, with showing pattern as cytoplasmic granular or formalin fixed with perinuclear sensitivity. The result was positive for P-ANCA and negative for C-ANCA.
Priyanka was positive, no?
Yes.
Yeah.
Yes, sir. UPCR was done. Urine creatinine was 13.7 and protein was 103. UPCR ratio was 7.513. Renal Doppler was done, which was normal.
Proceeded with the kidney biopsy as well, with the pediatric nephrologist coming into the picture.
Okay.
Sir, on kidney biopsy, there were predominant fibrocellular crescents and sterosed glomeruli. Ultimately, the diagnosis that was given by the pathologist was crescentic glomerulonephritis.
Rapidly progressive.
Yes.
clinically rapidly progressive crescentic glomerulonephritis.
And the final diagnosis, as rightly suggested, was ANCA-associated vasculitis. Abhi, you can just go through a couple of slides on this ANCA.
Yes, sir. ANCA is anti-neutrophilic cytoplasmic antibodies. These are antibodies that are directed against proteins of cytoplasmic granules or the other cytoplasmic constituents of neutrophils. The staining pattern produced by ANCA has been described by mainly two, that is P-ANCA, that is perinuclear, around the nucleus, and cytoplasmic, that is C-ANCA. The incidence rate is about 0.4 per million per year to 6.39 per million per year. The median age is around 10 years to 14 years, more common in girls. The following are the classification, that is microscopic polyangiitis, granulomatosis with polyangiitis, vaginous, eosinophilic granulomatosis with polyangiitis, and isolated necrotizing crescentic glomerulonephritis.
So in this case, with P-ANCA being positive, we would probably zero in on microscopic polyangiitis.
Yeah.
Because in granulomatosis, we would get a C-ANCA.
C-ANCA positive.
Further management in our hospital, she was started on a pulse MPS methylprednisolone. Oral steroid continued post MPS, that is from 2 mg per kg. Oral hypertensive was later slowly tapered. Patient distress and edema was increasing, so we did ultra filtration was done by securing HD line. Patient was discharged on the plan of alternate day ultra filtration and eventually CAPD for the renal condition. Injection rituximab was also planned, but due to financial constraints, we were not able to initiate it immediately.
So I think this case was quite brilliantly dissected by both our crackers, and in spite of my efforts to mislead, they stuck to the task, and quite early they zeroed in on the right diagnosis. So thank you on behalf of myself and Abhishek and SKN Medical College for allowing us to present this case. And I would stop sharing the screen and ask Dr. Sanjay Joshi sir to take over.
Thank you, sir. Thank you. It was a very excellent discussion. I congratulate Dr. Mahesh Kore, sir, and Dr. Lina Dhande, madam, to be the first Sherlock Holmes of this series, of this session. And I really enjoyed the discussion. I really thank you, both of you. And Nathu, sir, it was a very excellent case, very excellent presentation, Abhishek. Congratulations, Mahesh Kore, sir, and Dhande, madam. For solving this case very nicely. Thank you.
I must congratulate Dr. Dr. Abhishek as well as Dr. Sanjay have done a very great job at working up the case as well as treating the patient excellently. Thank you, sir.
Very nice.
I should thank
you,
both the teams, Sanjay and Abhishek, for giving a proper history. Yeah, that proper history, edema was important. That has come first and then it has. So we could solve that.
Very
Thank
nice.
you, sir. Sanjay, sir.
Thank you so much, sir.
I request Minas sir to please give some comments. Minas sir, are you there, Minas sir?
You have to unmute yourself, Minas sir. Unmute. There is a button. You have to unmute yourself, Minas sir.
I think Minas sir is not there.
Hello, good
Yeah,
evening.
he's there. Yeah, he's there. Yeah, done, sir, now.
Hello.
हो गया sir, हो गया.
Sorry,
okay.
sorry. I think I have been attending this kind of case presentation and dissection since long, but this is one of the finest case which has been presented by Dr. Nathu and his team, well worked up and equally well dissected. See, the entire objective of the case presentation is how we process it, and it was very well processed by Mahesh Kore sir and our own. In fact, both of us are our own, Leena madam and Mahesh Kore sir. And sincere thanks for being with us again and doing the great. Nathu sir, Leena madam, and the entire team, our Mahesh sir and the entire team. Thank you.
Thank you, sir. Thank you. I request Dr. Jayashivalkar madam to give a vote of thanks. Madam, are you there? Hello.
Madam is there.
Yes. Am I
Madam,
audible?
Madam,
Yeah,
1
yeah.
minute. Wonderful presentation, Abhishek and
Yeah.
Natu sir.
Thank you.
Very wonderful case and good beginning. Good beginning is half done. So I think this case has definitely help all the Mahapians, and they will develop a curiosity about the next case. So I think our job up just opening their eyes and how to go forward with any case, means any patient coming in your IPD or rather in the OPD also, we got a very less time, and still how slowly you can by properly going proper taking the history, then examination of the patient, you can avoid the unnecessary investigations and the treatment also. So thank you again, once again, thank you for starting this particular program. Thank you, Sanjay Joshi sir and Minhas sir.
Thank you,
Over
sir.
to
Jai
Jai
Madam
Madam.
want to speak. Jai Madam, yeah.
First of all, I would like to thank President Dr. Sanjay Pakmude sir, Secretary Dr. Amol Pawar, for giving us always innovative ideas, and they are always motivating for variety of programs. I have personally experienced that. So thank you, sir. I sincerely thank today's experts, Dr. Mahesh Kore sir and Dr. Leena Dhande, for their interesting discussion. And we all must appreciate and thank Dr. Sanjay Nathu and young pediatrician Dr. Abhishek Srivastav for wonderfully presenting the case and keeping the interest till end. And I thank Dr. Sambhaji Chate for running the program so smoothly. And as always, thank you, Dr. Menad sir, scientific chairperson, MahaIP, for always giving interesting scientific content. As well, Dr. Sanjay Deshmukh for his presence and expert comment. I thank Dr. Sanjay Joshi sir for his presence and welcome address. I thank Dr. Pranoti for giving me this opportunity for vote of thanks. I thank Team MahaIP as well as the technical support, Pallavi Madam, for smooth online conducting the session. And thank you all participants without whom this program cannot be successful. Thank you so much.
Thank you. Thank you, madam.
Thank you, everyone. Thank you.
Mahesh
Thank
sir,
you.
Leena,
Thank you,
Sanjay sir,
Forest,
Leena
Mahesh
madam.
Kore sir. Thank you, Leena.
Thank you.
Thank
Thank
you,
you.
Very
Natu
good.
sir.
Very
Thank you,
good.
sir.
Guys.
Thank